we talked about going over some of the didactic today. Is that kind of the plan that you have, or are we gonna look at some cases?
Yeah, I thought we'd probably start looking at some of the didactic stuff. Have kind of my typical fundamental stuff pulled up,
Sure.
ready to go. Probably start out with I think most of the original stuff is going to be more lumbar based. Then we'll kind of maybe go through the different types of primary pathologies for the lumbar spine. Kind of look at like the level one, basic versions of those different pathologies a little bit, and you just get kind of a baseline of what those things look like. And then we can kind of expand on those in the next couple of sessions. And then hopefully we'll be able to leave enough time here, week wise, going into the next course, to get into like the functional anatomy of the SI joint and all that sort of stuff. So
It's
uh,
perfect.
it's not quite as much as what we've had kind of early on. Just because those first two, three courses, there's so much like just concept stuff, the idea of facilitation and capsular patterns and end feels and all that stuff that we really have to kind of hammer home. So now that we're kind of at a point where most of you guys should be, feeling relatively strong about a lot of that stuff, we can kind of move on to some other things and hopefully it'll all work out here. But do we have any questions, concerns, anything that you guys have run into in the last week or so that you guys wanted to discuss before we get started?
I had some questions.
All right, let's hear them.
What I've been noticing with patients, like, if they have a UFER, they'll then have like thoracic spine ring shift kind of presentation too, or ring lesion. Is that something that we could expect to see like consistent,
Yes.
or is that just something I've noticed?
No, I mean, I think it's not something that I would call a hard and fast rule that you will see a ring lesion every time you see a UFER. That's probably not going to be the case. But when you think about, what a UFER will do to somebody, especially if they're active, um, it's going to cause some sort of compensation, right? So it's going to affect hip extension, hip internal rotation. So kind of the terminal stance phase, push off phase of striding. So if they, do a fair amount of walking, if they're on their feet a lot, if they're a runner, if they're, weekend warrior type and they're doing a lot of upright activity stuff, it's going to affect basically how that transfer of load is going to go from that leg into the trunk, right? And so what we will often see is if we're kind of stuck here and we can't get that, say it's the left hip to extend very well, it's going to kind of tilt us in a particular direction, and that's going to affect kind of the general positions of the rings relative to one another and relative to kind of the foundation of the lumbopelvic unit, so that around the pelvis itself. So we can certainly develop some sort of ring lesion as a result of that. It's going to depend, I think, a lot on what their, kind of meaningful task is, what it is that they're doing. But it's not uncommon at all to see ring lesions associated with a UFER. I just probably wouldn't say that it's a definite thing. I told you guys the last course that when I see, actually maybe it wasn't even over on the course, maybe it was just on one of these Zoom calls. When I see coronary ligament irritation, so it's particularly lateral coronary ligament irritation, almost 100% of the time the issue is going to be caused by a loss of subtalar eversion. Okay, and that's one of those profiles that's I'm like, this is almost 100%. I can't remember a situation in which I've seen somebody with a positive coronary ligament irritability and not having a loss of subtalar eversion. So that's one of those things where I'm like, yeah, if I see this, then this is going to be there. Um, I don't think it's quite that high a probability with the UFER and a ring shift, but yeah, it certainly is something that you can pick up on. And like I said, if there's a certain pattern that you're noticing, like, oh, this person's a runner and they're doing this amount of distance and it's this amount of volume over the course of the week, then you can probably say, well, I would anticipate them having X problem elsewhere, right? Whether it's a knee issue or whether it's a thoracic spine issue. So yeah, definitely a possibility, but I wouldn't sit down here and tell you for sure, yes, expect it to happen. Dave, what do you think?
Yeah, when you have as soon as you have the hip and you're in the pelvic floor world, I would look at it because you're probably going to have a compensation somewhere for what the rotation is going to do. So it's one of those ones where you're going to see it. And it's not going to be a hard ring lesion sometimes, but you can could just be a myofascial twist where the
Mm.
system just twists in response to it. It's not like it's stuck in the rotation. It's just a twisting motion to kind of recenter the body, especially Courtney, you're in kind of in the pelvic
Yeah.
world and
Well, it's
correcting that
usually,
ring lesion and hip. You may be able to correct the ring lesion. It could be myofascially twisted as a correction, and that's gonna reset the pelvic canister.
that's kind of what it's mostly in the postpartum population. I'm seeing that. It's almost
Mhm.
like, uh, and I don't know if this is right or not. It's almost like they end up with a UFER to help them stabilize. Does that make sense? Like they need stability somewhere, so they are like locking
So part of that would
anteriorly.
be you think about the obturator was the obturator internus membrane and pelvic floor together. You have obturator internus coming over into the lateral hip. So oftentimes with the UFO, what you're going to see is up ramped external rotators and facilitation and tone as those muscles are then overstretched in that position. So that could be their potential, and you can load that pipe at a nine, that could be their potential stabilizing mechanism as part of that and that up ramp and facilitation. So when you take it away, I'm not quite sure 100% of the implications in the pelvic floor. It's something you can play with, and I'd be happy to hear what you say. But absolutely, you're going to find the UFER or the hip, even that is not subluxed, that's living in that position with the facilitated external rotators and possibly a ring lesion as well.
Yeah, I
Yes.
If
think.
you ever, Mhm.
Sorry, I think when you do when I forgot about the pelvic floor component that you deal with a lot, Courtney, but um the idea with postpartum, and I've seen a lot of them in my lifetime for whatever reason. I got some sort of reputation about being good with them at some point here in Denver, so I started seeing a ton of them all the time. But one thing that you can get with the effect of these postpartum kind of twists through the pelvis, right? I mean, I'm not gonna make any kind of terminology, assumptions here, but those obliquities that we can get through the pelvis, one of the major things that will be a resultant of that is abnormal kind of length tension relationships of the pelvic floor musculature, right? So what we'll typically see is we'll get one side that's really grasping really hard to try and hold things together, and the other side now all of a sudden may be inhibited because of the position of the innominate relative to the femur. And so when you get that pelvic floor mechanism being inhibited, what tends to happen because a lot of those pelvic floor muscles and posterior pelvic wall muscles will effectively function as hip external rotators, it will tend to allow that femoral head to kind of drift forward or potentially even to internally rotate, right? And so those sort of things can lead to kind of that deviation of the femoral head in and of itself. So that sort of scenario, and the reason I'm talking about this in a separate kind of situation is that postpartum females is one of the few kind of exceptions to the rule that SI joint and pelvis issues are usually going to be secondary problems, right? So typically in a healthy adult, right? And we don't want to necessarily say that pregnant females aren't healthy adults, but they're fundamentally altered from a physiological standpoint. They're very mobile through the pelvis. So they're able to develop what we call primary pelvis issues as a result of that, right? Kids under the age of 12 years old or so, they're another one. They're just not fully developed. The SI joint's not fully developed, so it's able to create a little more movement. It's going to have a little more movement available to it just because of the undulations and kind of that the morphology of the joint itself is not going to be as um, it's not going to be as adherent to its general position. And then the other one would be somebody that has some sort of systemic inflammatory condition that's kind of chewed up that interosseous ligament um, that essentially kind of destabilizes the joint, right? And so those three risk groups are capable of producing primary SI joint issues or pelvis issues. But other than that, most are going to be caused by some sort of secondary problem, thoracic ring lesions or thoracic spine lesions, hip issues, foot and ankle issues, lumbar spine problems, all these different things. They tend to be the thing that was there first that then affects the position of the SI joint. In postpartum females, that's not the case. So they can kind of develop the U first secondarily to the initial pelvis issue. right? And a lot of times that's just these kind of fixated obliquities that occur during pregnancy that once things kind of start to tighten up, they kind of get fixated in that abnormal position. And then that motor tone is just thrown for a loop, right? It's just not quite right. And so all of a sudden the hip itself, because of the interconnection between that lumbopelvic hip mechanism, it just can't hold itself together very well. I don't doubt that it's possible that these EUFR issues, they're thinking, well, we need to kind of anchor ourselves down here to hold this thing together. But what I'll typically see is we'll get one side of the pelvis that'll get real tight, where the pelvic floor kind of pulls us into this almost it's like a superior tilt sort of position. And so the other side kind of does a tilt in the opposite direction where we get more tone out of the, what am I thinking here? Quadratus lumborum and some of the hip abductors contralaterally on opposite sides that'll kind of create that tilt through the pelvis. So certainly definitely a possibility there, but that's a different conversation from, kind of the EUFR plus thoracic spine stuff, because the EUFR in that situation, once a primary issue, is more the secondary problem than it would be the primary problem. At least that's the way I would look at it.
It's fun stuff, Courtney. It's great you're picking up on this because you're going to
Yep.
be living in through here as well, and even kind of playing it off the foot as well from the
It's so
thoracic
fun.
spine.
It's been a lot of fun to
Yeah,
play around with it for sure.
thick
And
stuff. Yeah,
and the
I
best
kicked
part of
you.
it is the best part of it is when you can start to predict what the next problem is going to be. Right. So if you take a patient that comes in and you're like, well, they've got this EUFR issue and I'm suspicious it's being caused by some of these pelvic floor issues, you can say, well, what else might come as a result of that? Because if you can start to predict it and then you go and look for it and it's there, then your thought process as far as how the system is integrating itself and how these different things are playing off of each other, that's really kind of the grand finale. That's what we want you guys to be able to do, is to pick up on, what's next or what else might be contributing to this as part of the etiology, kind of that driving mechanism. So when you guys can get to that point and really kind of make those predictions about what might else be, going on with these people when they walk in the door, you're gonna have a lot more success with carryover when you're able to do that stuff, because you can say, okay, if I'm thinking, you know, hip hip driven, uh, pelvis driven hip, that sort of thing. What else might have come as a result of this? Is this going to affect this portion of the lumbar spine? Is this going to affect this portion of the lower thoracic spine? And you kind of look for those potential issues that you might expect, and you see them there. You're like, okay, good, because those things can be perpetuating problems that keep those issues kind of lurking around on you. So that's good stuff, though. I like it. What else? Anything else? Other questions? Anything else you wanted to add there, Dave?
No, that's kind of it. I kicked you over some resources, Courtney, too, on that as well.
All right.
Thanks, Dave.
Good. Anyone else?
Nothing else? All right. Am I good to share here, Dave?
It could be.
Okay. I'm gonna
Nobody should be blocked.
pull up this thing here. Get everybody out of my way. I can see. All right. So you guys know I have one of these pretty much for every module that we do, right? It's just kind of an introductory thing. Kind of go through some of the fundamental things that we need to know. Now, most of these fundamental things are going to be things that we've already covered. We talk about segmental facilitation and we talk about force output and all those different things and kind of where these inhibitory processes might come from. Neurological versus neurophysiological. These things all still apply, and we'll kind of review those things as we need to going forward. But I want to get to some of the things that are kind of unique to the lumbopelvic region so that we can kind of start working off of this stuff. And I think just the way I organized this is I think I started with mostly the lumbar components here. And then we kind of work our way into more of the SI joint and kind of the functional anatomy and things like that. So we'll get started with it from this perspective. If you have any questions, feel free to, either throw up a hand there or put it in the chat, and I'll try and keep an eye on the chat. But Dave, maybe if you can keep an eye on that for me too, since I may not be able to see
You
it.
got it.
Yeah, we'll take a look here. So I, in general, I don't think the lumbopelvic region is as difficult as everybody wants to make it out to be. I know a lot of people coming out of PT school, myself included, looked at the sacroiliac region and was just like, I don't know, I'm going to do some traction on the hip and I'm going to do some gapping in the lumbar spine and I'm going to give them some exercises and we're going to cross our fingers and hope that fixes the problem. So don't feel bad if that's kind of the way you viewed it, either up to this point or at some point in your career, because that's exactly the same way that I saw it. But I think once you kind of understand, and I will try and I don't want to give you guys what I would consider a formula, but I will give you guys what I consider a process that you can go through as far as the examination methods go. Kind of step, A through E or F or so whatever it ends up being. Um, kind of the things that you can check off your list. Now, there's certain ways that we go about that process where we use certain screening tests. And again, I've talked a lot about screening tests, but they're just those simple little things that you can do. Take you a minute or two, or if not less, to go through and look at kind of the overall functional capacity of a particular body region, so that you can say, yes, I need to go in and look at this further. There's something going on here. Or nope, this screening test looked pretty clean. I can wipe that whole thing off of my checklist here. So it's really very functional, really very effective, and super efficient if you get real good at doing it. So like I was talking about before, the lumbopelvic region is probably difficult for most people because of the fact that it's affected by so many other body regions. Um, Again, it's most of the people that walk in through the door that have some sort of sacroiliac or lumbopelvic dysfunction, right? Particularly the ones that have sacroiliac pain, which should be relatively easy to pick up on. Um, they are going to have some other primary driver that's forcing this thing to become problematic. Okay. And that's going to be our long-term goal, is to find out what that etiology is, what that driving mechanism is, so that we can fix it. Because I can go in and I can do a manipulation of an SI joint all day long, and they could come back every day for a month, and it will be exactly the same as what it was the first time I looked at it if I don't fix what that driving mechanism is. And again, there's kind of those three primary risk groups that can develop primary SI joint pathology. Um, Pregnant females or early postpartum females, um, systemic inflammatory conditions, people with things like ankylosing spondylitis, rheumatoid arthritis, reactive arthritis. We went through a whole list of them during the last course. And then children under the age of 12 that don't have the adequate development of the pelvic ring to make it as stable as it needs to be. Okay, so there is, and I'll mention this, I usually mention it, but I tend to forget about it very quickly after the fact. There is a fourth high risk group for primary SI joint pathology, and that is severe trauma. It's always been listed that way in the curriculum. It was in the curriculum when I went through it. I find it hard to believe that we're going to sustain significant enough trauma to primarily affect the position and mobility of the SI joint. So again, I don't think you're going to fall on your backside hard enough to sublux your SI joint if you're an otherwise healthy adult, right? So if that's the case and somebody slips and falls and hits their butt on the stairs in the wintertime, and they come in and they've got an upslip or they've got some sort of, you know, traumatic subluxation of the sacroiliac joint, odds are this person also has some underlying factors that are contributing to how this sort of thing happened. Whether it's the thing they had a old sacroiliitis that chewed up the interosseous ligament, or if they have some sort of simple positional obliquity that's been occurring kind of under the radar for some period of time, and then they slipped, and all of a sudden it kind of damaged some of the surrounding tissue. So, again, take that with a grain of salt as far as that severe trauma. I personally think we're more likely to fracture either the sacrum or the innominate bone itself than we are to traumatically injure the sacroiliac joint. It's just that stable, that powerful of a joint. Um, so again, take that for what it's worth. It's not that it can't happen um, with enough trauma, but I think we're going to have other issues that are going to be more likely going to be your primary concern. Dealing with a fracture or some sort of other issue, versus what's going on with the SI joint if it's done traumatically. Okay. So here, right here, what we have is just kind of a short, brief list. I don't think it's by any means exclusive to these things. The things that can affect the lumbopelvic region, thoracic spine lesions, I think ring lesions are probably the most likely to cause sacroiliac issues. It's not that a rib or a facet lesion cannot do it. It can certainly affect kind of the position of the pelvis. I think it's going to take a longer period of time for that sort of thing to happen. I do think the ring shifts because of the way we get these twists in that ring and how that's going to affect some of those long thoracic paraspinal muscles, particularly the iliocostalis. I think that's the most likely scenario. Is going to be a ring lesion, is going to be the most consistent thing that's going to affect it. But again, it's not a hard and fast rule. Um, so obviously the pelvis itself, so sacral torsions, um, things like we were just talking with Courtney, postpartum, obliquities, things of that sort of nature can affect the SI joint. Then the hip itself, very common problem, whether it's because of it creating some sort of functional leg length discrepancy, or if it's creating an inhibitory process or a facilitatory process on some of the musculature. So say an inhibitory process affecting the short hip external rotators, what's that going to do to the position of the sacrum relative to the innominate around it? Or if we have some sort of hip issue that's creating an increase in tone, which is very common of, say, the psoas major, what is that going to do to not just the position of the sacrum itself, but the lumbar segments above that? So again, hips very common to have problems. Lower limb, kind of lumped everything together here. Loss of terminal knee extension or genu recurvatum, those sort of things can cause an effect, can have a cause and effect issue as far as that functional leg length. Whether we're able to lock things out. Do we need increased muscle tone of, say, the hamstrings, for instance, in order to help produce stability of the sacroiliac or the lumbopelvic mechanism, particularly the biceps femoris because of its attachment um, to its component attachment to the deep longitudinal sling, which is a muscular sling, and we'll talk more about the components of those as we go forward. Is it a foot and ankle issue, a talocrural subluxation, or anything along those lines that limits the ability of the ankle to be effectively mobile, subtalar joint, all these different things in the lower limb can affect pelvic position, pelvic rotations, all these different things. Um, Primary lumbar pathology, we're going to talk a little bit about that today, what the kind of the three major types of primary lumbar pathology. These can certainly create problems because what this is going to do is it's going to affect kind of the resting um, coordination and that length tension relationship between the various muscles that go through the lumbopelvic mechanism, right? So if we have, for instance, an old disc lesions tend to create a significant inhibition of the psoas major on the ipsilateral side. Okay, I'll say that again. Old disc lesions or even traumatic disc lesions, recent acute disc lesions, they tend to create inhibition of the psoas major on that ipsilateral side. And basically, the idea is we don't want to put weight on the side that has the disc lesion. So if we have a posterior lateral protrusion or a herniation on, say, the right side, the body is going to tend to kind of shift to the left. In order to do that, we have to kind of inhibit that psoas major. So all of a sudden those functional antagonists, the psoas major and that opposite side group of short hip external rotators, kind of their tone, their resting tone is now not going to be in sync, right? And so all of a sudden we have the situation where the sacrum itself is going to start getting these kind of oblique torsions that go through them. And we'll talk about sacral torsions at length during the course. Um, how to assess for them, how to treat them, all these different things. So all those different things can cause problems. I will tell you this, and again, this is not what I would consider hard and fast rules for this. If we have either a thoracic lesion or some sort of lower extremity lesion, that includes the hip, okay, hip, foot, ankle, knee, etc. Either of those two things, they're more likely to cause an innominate rotation than a sacral torsion. Okay, sacral torsions are more likely to be caused by primary lumbar pathology. Okay, disc lesions, segmental instabilities, even stenotic changes, things like that are more likely to cause sacral torsions. And again, when we're looking at innominate rotation versus sacral torsion, it's a relative term, right? So what is being forced to move? Is it the innominate being forced to rotate or move relative to a more fixated sacrum, or is it the sacrum that's being forced to move in between the two wings of the innominate? Um, that's the way I've always viewed these things. So if I'm looking at, I've got a thoracic issue, I sit a patient down and I ask them to do my seated rotations, which is a good screening test for that. And I say, yeah, they're not real good going to the right side. Okay, I might have a thoracic lesion and I know that they're dealing with pelvis pain, pelvic pain, probably SI joint pain at that point. Then I'm pretty comfortable saying that the pelvis issue is more likely to be an innominate rotation than it is a true sacral torsion. There are, of course, always going to be caveats to that rule. T12, some TL junction issues can function more like a primary lumbar pathology than they do a true thoracic ring issue or facet issue or rib issue. So we have to kind of take that into consideration at times as we go through this. Now, I will say if we have a TL junction issue that's affecting the pelvis, it's most likely to be occurring via the quadratus lumborum. Okay, and tone changes, resting tone changes of the quadratus lumborum, creating kind of this anterior innominate tilt as it kind of pulls up on the posterior elements of the innominate. Okay, so again, hopefully that makes some sense. If we have thoracic or lower extremity problems, you're looking more likely at an innominate rotation. If we have a primary lumbar pathology, you're probably more likely looking at a sacral torsion. Percentage wise, I would say that I'm pretty comfortable saying that that's going to be the case. Um, but it's not a definitive statement. Okay, so don't take it that way. So again, all of this being
Rick,
said,
can I
yes,
do, I got the what's going to cause the more likely cause an innominate rotation.
yes.
What did you say was more likely going to cause a sacral torsion?
Some sort of primary lumbar pathology. So a disc lesion, segmental instability or segmental dysfunction within the lumbar segments, or maybe even an old stenotic issue. An old stenotic issue, and we'll talk more about this, what would cause it, is most likely to be set off. It's a cascading effect. So we have something that damages one of the lumbar segments, whether it's a disc lesion or if it's a traumatic arthritis or whatever it might be. And all of a sudden, this segment starts to break down. It doesn't move as well as it used to. The disc lesion, acts kind of like a physical block. A traumatic arthritis creates a capsular pattern. All of a sudden, it doesn't move as well. The disc starts to deteriorate. The segment becomes unstable as a result. And then over time, because of this instability, the body starts to build up scar tissue in order to help restabilize that. So the stenotic change is kind of a couple of steps down the chain here, probably from some other old lumbar pathology. So, but those things, disc lesions, segmental dysfunctions or segmental instabilities, and then potentially stenotic changes are more likely to create those sacral torsions.
Eric, could you repeat the QL and the TL junction
Mhm.
dysfunction?
Sure. So I think we talked about it during the thoracic course, but the TL junction, particularly the 11th and 12th segments, vertebral segments, and then the 11th and 12th ribs, if there's dysfunction there, one of the major symptoms that a patient's going to complain of is flank pain, right? And so that's going to be kind of that pain that's just, it's above the iliac crest, but it's below the ribs. It's right over basically where the quadratus lumborum is. So if I have, say, a right-sided T11-12 restriction, right? 11 on 12 doesn't rotate very well. One of the first things that's going to crop up with this patient is the QL on that side is going to do this. It's going to say, nope, I don't want to let go. I'm going to try and hold this. I'm trying to either not allow any further damage, or I'm spasming because we're not necessarily spasming, but I'm hypertonic as a result of abnormal kind of proprioceptive and mechanoreceptor feedback through that segment. So it's going to tighten up on us. And so when that happens, if the quadratus lumborum starts to create an increase in tone, coming down from the ribs, it's going to take the posterior elements of the innominate and it's going to pull it superiorly, right? So what that's going to do is it's going to create this anterior tilt of that side of the innominate. Okay, so that's a very common problem that we will see that people will complain of, potentially SI joint pain as a result, right? So the problem with the TL junction is that because some of those components, particularly T12 on L1, function very similarly to lumbar segments, the rest of the lumbar segments, that particular region could also potentially cause a sacral torsion, right? Because of its effect on um, psoas major and potentially on some of the short hip external rotators and how those dynamics kind of counterbalance each other. Because the psoas major and the posterior pelvic wall, so the short hip external rotators. So we're talking about the obturators, we're talking about the piriformis, we're talking about the short component of the gluteus maximus. These muscles, they are the functional antagonist for the contralateral psoas major. Okay, and that's just a fact during gait, during ambulation. Okay, so if we have increased tone of, say, my right psoas major, the contralateral posterior pelvic wall is going to be inhibited naturally, right? That's our reciprocal inhibition of functional antagonists. So we're going to have that asymmetry between those two things. Okay, so in those sort of situations, when we have that, very easy to create a sacral torsion, right? Because now all of a sudden the sacrum's sitting here and I have my short hip external rotators attaching to this ILA on the left side, and the psoas major up here these are inhibited down here, not working as well, and the psoas major is real tight and has increase in tone. What's going to happen is that's going to pull that forward while this is going to allow that to drift backward, right? And so that's what's essentially will cause a torsion, right? So we'll talk more about, I'm not going to get too much into because I'll waste the next 25 minutes very easily talking about how you name these things and kind of the various different components that go with that. But that tends to be an issue mostly with lumbar pathology, those sacral torsions. Okay, any other questions with that before I move on? Okay. So this is probably where it becomes difficult for people is realizing that, okay, I have an SI joint issue, right? So for me, if I'm looking at somebody in a lumbopelvic scan, right? I'm doing an examination of the lumbopelvic region. The first thing that I want to do is I want to see am I dealing with pelvic problems here? So I'm going to do a Portland test. We talked about this during one of the courses that I was there for, where you get them into a stride stance and you push on that sacroiliac joint of the forward leg, and you just see if they're able to absorb that external load, right? And if they're not able to, then it tends to suggest that they're not able to transition load through the pelvis as effectively as they're supposed to. It's one of the best screening tests that we have in the human body. I probably said the same thing about the quadrants in the elbow because we get additional information. But the Portland test is so simple. It's so easy to do. You can do it right away as soon as somebody walks in the door, and gives you that Fortin's point where they kind of say, yeah, it hurts right over here. That's one of the first things I'll do is just to say, okay, is there dysfunction here? All right, good. There is. I got it. Now I know I can start looking at what are these other potential body regions that could be causing this problem, right? I've got a screening test for the thoracic spine, seated rotation. I've got quadrant testing for my hip. I've got, active passive, active passive resisted testing for my knee and for my ankle. I've got quadrant testing for the lumbar segments. These things are easy for me to run through and basically give me this yes or no answer where it says, yes, the test is positive. I have to look at that deeper. Or no, this test is negative. Sweet, I can wipe that off my list and I can move on. Okay, so but that's where I think most people find this difficult, is that once you find that yeah there is a pelvis problem and particularly an SI joint problem, now I've just started, right? Now my examination can really get going and I can start looking for where these potential etiologies are coming from. Okay, now that we're one slide in, finished with one slide, we can start moving on. A couple of things here as far as, why is this area so important? Providing a stable base for gait because this is a situation. This is why the Portland test ends up being so effective, right? Because we put them in a stride stance, basically the same position they'd be in right before they go into heel rise, and we're saying, can you absorb any type of external load here? Does the wind blow? Does somebody bump into you? Does your dog pull you in one direction or the other? Can you absorb this sort of external load? If this isn't a stable base, if there's dysfunction in this system, then it's going to throw us off, and we're going to have poor balance reactions, and it just causes potential for, additional problems to kind of come up. So, um, definitely houses the driving mechanisms for initiating gait, right? So this is kind of the idea of overcoming inertia. How do we get ourselves started from a dead stop here? The psoas major, we talked about, God, way back in what was it, module one even? We were talking about Grakovetsky's work and the spinal engine papers that he's written. Um, I really believe that this is the case. The psoas major is the primary driver for human ambulation. Glute max is very important as far as being able to overcome that inertia and be able to get somebody propelled forward, particularly if we're moving from, what we'd kind of consider quiet ambulation to jogging to running. It becomes much more important. Um, but there's really kind of three factors here that kind of come into play when we talk about gait. And pretty much all of these are within the lumbopelvic slash hip mechanism. Okay, so the first one is the ability to create a lumbar lordosis. Okay, so being able to create a lumbar lordosis vastly improves our efficiency because it helps us to produce the second component, which is a hip that extends beyond neutral. Okay, so other primates, they don't have hips that extend beyond neutral. And so they don't have that same efficiency. They don't have that same kind of twisting and tension that occurs through their lumbar spine, through the musculature, like the psoas major, for instance, the anterior femoral fascia, all these different structures, including things like the IT band and the TFL. All these structures, they become stretched, they become tensioned, and then they help to, once they recoil, once our heel lifts and the knee starts to bend, all of a sudden it's this kind of elastic recoil that helps to produce that swing through effect. So those things become very important. And then the third thing is the Q angle of the hip itself, right? So of the femoral neck. Um, this is one of the things that kind of narrows our base of support, allows that kind of reciprocal walking where it's almost like our feet are kind of going in front of each other. Um, that makes us very much more efficient because it allows for internal rotation of the hip as we go toward terminal stance phase where the hip is in an extension position. Again, this torsions all of those anterior hip structures. So things like the Y ligament and all the different capsular ligaments that are associated with the hip itself, they become tensioned. And so again, this passive generation of kinetic energy that we're able to build up because of all these different factors becomes very effective, right? But the lordosis and that hip that extends beyond neutral, if we think of what should happen to my lumbar spine as it lordosis. It's not really just a pure lordosis. It's actually a scoliosis, right? And it's realistically a rotoscoliosis when it occurs. The idea is that because of the tension on the psoas muscle, right, and the attachment points of the psoas to the anterior portions of the vertebral body and to the anterior portions of the transverse processes, what it's going to create is an ipsilateral side bending. So if it's my right side, it's going to create an ipsilateral side bending, then a contralateral rotation, and an extension, right? So that's our what we've kind of defined as a latection moment, right? We're adding in the extension component, the extension moment with that. That's the lordotic component. But essentially, that ipsilateral side bending with contralateral rotation, it's very much a latection moment. So it's a very effective, what we would consider the prime functional coupling of the lumbar spine. Now, it's not that the lumbar spine can't do side bending right and then rotation right. It's very capable of doing that. But from a functional perspective, I would look at it as side bend right, rotate left is its true functional capacity because of ambulation. So it's probably why when we look at some of the literature that tries to define the functional coupling of the lumbar spine, it says things like L1 to L2, it's coupled ipsilaterally, L3 and 4 is coupled contralaterally, and L5 doesn't really move very much. And they all have these different percentages and things like that. And it's just like, yeah, the reason you can't determine this is because functionally it can do either one. But when we're looking at what's the true function here, what are we looking at from a perspective of what's a person likely not to be able to do here? If it's an ambulatory issue, then it's going to be a contralateral coupling. Okay, so again, just something to kind of keep in mind there. So lumbar lordosis, hip that can extend beyond neutral, and the Q angle of the hip. Okay, those are the three factors there that really initiate that scoliotic curve. And then we have, something that's very near and dear to Dave's heart, the ability to transmit load from the lower quadrant through the lumbar spine and into the thorax, right? This is where Dave's favorite term in physical therapy, failed load transfer, comes from, right? The inability to transition these loads becomes a problem because where does it get stuck, right? So if we have kind of this energy, this force vector that's coming up through the lower leg, and it needs to transition through the pelvis to get into the lumbar spine and eventually into the thorax. If we fail at that, right? If we don't have the ability to move the pelvis appropriately to create that sacral torsion or relatively that innominate rotation, we're not going to transition that load very well. And now all of a sudden, that load is kind of stuck either in the pelvis or at that lumbosacral junction. And eventually it's going to break that down because it's not designed to absorb the entirety of that force. It's designed to transition that force or attenuate that force as we get into the much more mobile thoracic region, right? So I think that's something that we have to take into consideration. We have something on the chat there we need to discuss there, Dave.
Now, Courtney's just there cheering me on.
Makes sense. Gotta have it sometimes, right? All right. So how does this differ from other regions of the body? I mean, most of this is going to come into with the functional anatomy stuff. But the lumbar segments in general, they're designed for vertical loading, right? They are designed to take compressive forces and do so in an effective manner. So when we have this lordotic curvature, right, that arch is actually much stronger for us, especially when we couple it with the kyphotic curvature of the thorax. It's much stronger and able to tolerate these vertical loads while still providing sufficient mobility. Okay, so really much more designed for that than say the thoracic spine segments and especially the cervical spine segments. When we start talking about the disc anatomy, and we'll get to it eventually, maybe not today, but at some point during these calls, and we start seeing this clefting that occurs through those discs. So particularly in the cervical spine, but it'll also happen in the thoracic spine. We start thinking, well, these things are more designed to absorb torsional loads, right? Rotational loads as opposed to vertical loads. Okay, because we don't get the same clefting in the lumbar spine. Orientation of the facets. This is a big one for me because they're in the sagittal plane, right? They sit like this. Okay. but there is a slight anterior curvature or even a hook. So it's either C-shaped or probably more J-shaped, I would suspect, um, or L-shaped, where it's kind of got more of this straight, linear, almost more of a 90-degree angle to it. But what that does is it resists an anterior shear, right? So it's just an adaptation to resist shearing anteriorly because the fact that the human body has developed this lordotic curvature, right? It's because now all of a sudden gravity, particularly on those lower lumbar segments, L4, L5, L5, S1, we're going to have more of this kind of anterior inferior shear that could occur. But because now we have this bony impaction where the superior segment's going to kind of bump into the inferior facet there, it's not going to allow much of that, right? So that's good news. That definitely helps us to resist that anterior shear. So when we start to see anterior instabilities, we know that there's probably been some breakdown of some of this structure. Thicker discs, yeah, we were just talking about this. There's no clefting involved with this. They should be thicker. Um, Kind of the downside of this from a trauma perspective, especially in younger patients, is a higher proteoglycan count, right? So the makeup of the disc tissue has more proteoglycan content to it. If there is inflammation and or blood introduced to the proteoglycan structure, it creates a very significant inflammatory reaction, right? So if we have a traumatic tear of some of the annular ligaments and there's inflammation associated with that, that inflammatory react, it's going to be like throwing gas on a fire is what it's going to end up being like. That inflammatory reaction is just going to burst out there. It's going to be much more substantial. And then all of a sudden we're dealing with inflammatory pressure or hydrostatic pressure from fluid. And that can just as easily cause not only scar tissue, but also palsy, right? Enough pressure on the nerve roots to create actual conduction loss as a result of that sort of thing. So that tends to happen, like I said, more in younger patients. So if you have I saw one at one point I was doing, oh my God, I was doing the medical tent at a CrossFit competition when I first moved back to Denver, and there was some guy that was doing some ridiculous deadlift thing and blew out one of his discs. And I mean, I've never seen a human being in so much pain in my entire life. It was instantaneous, like sciatica going down the leg. It was just so bad. But the guy's, he's 22. He's trying to lift all this weight and he's doing it as part of this competition thing. So he's trying to do it quickly. His form was terrible. And it was just this horrible scream. It was just awful. Um, but I mean, the idea there is this kid, right? He's in his early 20s. The reaction that he has to that sort of scenario is going to be significantly worse than if it happened to somebody my age in their mid 40s, right? Just because the proteoglycan count in my discs has been diminished due to the natural aging process. Okay, so that's definitely something that we have to take into consideration. Um,
Did the chiros there manipulate him to try and fix it?
no, the paramedics ended up having to take him out, but they couldn't even get him onto a table. Like it was just like somebody give him some Demerol and we'll get him on a thing and we'll
Okay,
get him into the ambulance
well,
here
that's
and get
good.
him
At
off.
least they did that. That's
Yeah,
always
it
Stuart
was
McGill's. That's always Stuart McGill's running joke. And that is that, yeah, if you look chiro, they're stretching out their discs and
do a
these events, and
rotational
then
manipulation on a
they're
traumatic
trying to rotation
lesion.
manipulate to fix it. Yeah.
My suspicion with that guy is he ended up having a pretty nasty end plate lesion, an avulsion fracture with that one, and so it's just this like it starts bleeding into the disc. He probably herniated part of the disc, and it was. I felt bad for the dude, but that's what you get sometimes when you kind of throw caution to the wind, and you don't do form the way you're supposed to with that stuff.
Looking for speed, baby.
Got to get through it, right? You gotta take first in that event. Resistance to rotation. We've talked about this plenty during the thoracic course. So um, the orientation of the facets is one of the major factors here. So if I rotate, they're just going to bang into each other, and it's not going to allow much to happen there. It's actually the longitudinal ligaments, believe it or not, that has the highest percentage of resistance to rotation in the lumbar spine, which I thought was abnormal. when I saw those numbers, but it is actually this. The annular fibers, so the orientation of the annular fibers, they're kind of at conflicting 60-degree angles here. Then through obviously the neural arch, which is a component of the facet mechanism there. So, and then obviously the associated musculature. But realistically, the lumbar segments here, they're not designed to rotate. They are designed to resist rotation. And it's important to remember that because when they resist that rotation, if you twist that and you compress those facets and you tension all those longitudinal ligaments and you tension the neural arch, the pliability of the neural arch and the annular fibers is when you release that. So when you release that twist, it's going to it's going to have such a forward kinetic spring to it, that this is why doing things like swinging a golf club or swinging a baseball bat, we can generate such enormous force, is because we have this spring potential that kind of comes into play. Now, if we force too much of this rotational force to go through the lumbar spine and we're not able to distribute it adequately either through the trunk, so through the thorax, the pelvis, or the hips, or even potentially down through, say, the joints of the foot and the tib-fib joints, then those lumbar segments are going to break down pretty quick because they're going to have to do a little bit more of this rotational. They're going to have to absorb a little bit more of this rotational force, and that's not good for them, right? That's an easy way to break down some of the annular fibers, to break down the neural arch, to break down some of these longitudinal ligaments and all these different structures, right? And so this is how things start to go south pretty quickly, okay? The neurology here, the cauda equina versus the spinal cord. I've talked about this before, and we should all be aware of this from an anatomy's perspective. Now, the spinal cord itself, the upper motor component, upper motor neuron component of the spinal cord ends around L1, maybe T12. There's some variation from person to person. So lumbar, even central lumbar pathology, like a central disc or some sort of osteophyte or um, space occupying lesion of whatever kind, it's not going to create an upper motor neuron issue in the lumbar area, right? It's going to create a lower motor neuron issue, but if it's central, it's more likely to create cauda equina symptoms, which is kind of that um, situation where it's going to affect the deeper components of the cauda equina, so S3, S4, so it's going to affect the girdle area. It's going to affect some of the pelvic floor mechanism. It's going to affect bowel and bladder function and all that different stuff, right? So the other thing that we have to take in consideration here is the angulations of the nerve roots. Okay, so in the cervical spine, the nerve roots come out like this. They come out horizontally, right? So it's really abnormal to have more than one level of the cervical spine be affected by something like a disc protrusion, right? The lumbar spine, because the cauda equina comes down like this, its angulation is steeper, it's more vertical before it exits, we can have more than one level affected. So we could have, say, an L4-5 um, paracentral or paramedian disc protrusion affect not just the L4 nerve root, but also potentially the L5 nerve root, right? So those sorts of things can happen. So it's if we have three or more segments that are involved in the lumbar area or in the lower extremity, that's when we're looking at that as more of a red flag, right? So if we have two, that's not necessarily considered a red flag in the lumbar region. But if we have three segments that are involved or more, then yeah, that suggests some sort of centralized compromise. It's affecting the cauda equina at that point. We all good with that? Oh boy. Got a lot of stuff here. All right, we only have a couple minutes left, so I'm gonna call it there for now without having to take up too much of everybody else's time. Plenty more stuff for us to go through on this. I know we didn't get through as much as I thought we would, and that's okay. There were a few questions, and I wanted to make sure everybody kind of understands what we're going through here. But the idea here is just to kind of understand, what we're looking